Hello everyone, welcome to our Foot Pain Causes and Treatment Options webinar featuring Mr. Barry Rose, a consultant orthopaedic surgeon specialising in foot and ankle here at the Horder Centre. I'm Josephine, Head of Marketing and Sales, and I'm delighted you've joined us this evening as we dive into a topic that affects millions of people every day, foot pain. We will shortly be hearing from Mr. Rose, whose practice includes the whole spectrum of foot and ankle conditions, ranging from sports injuries, ankle instability, tendon problems, foot and ankle deformity, arthritic disease, through to the management of heel pain, forefoot pain, bunions, and lesser toe problems. Before I hand over to Mr. Rose, just a quick reminder that this is a live event and the recording will be emailed to you tomorrow. We're not able to respond to raised hands, so please pop any questions into the Q&A box and we'll answer them at the end. If you'd like to stay anonymous, please just tick the box when submitting your question. And with that, I'm very pleased to hand over to Mr. Rose.
Good evening, everyone. I'm Barry Rose. I'm a consultant orthopaedic surgeon, and I have the pleasure of talking to you about foot pain conditions and treatment options. I specialise in foot and ankle surgery. It's the mainstay of my practice. It's a huge topic, and there are lots of things we could talk about, and we're going to go through many of those today in a little bit of detail, but there's obviously a much more detail that could be fleshed out if necessary. This presentation comes with a warning. It's dangerous. There are lots of pictures of feet. And for me, that's my bag. That's what I like doing, and I'm happy to look at them, but they're not all pretty. And just be prepared to be looking at some not so pretty pictures of feet. They're PG rated, don't worry too much. We generally split the foot when we're talking about different parts of it into the forefoot, the midfoot, and the hindfoot. And that's all fairly self-explanatory. So broadly speaking, this talk's going to start with problems around the forefoot, then heading towards problems in the midfoot and more towards the hindfoot after that. So we're going to start off with a common question that I probably most commonly asked or get seen and get asked in clinic. What is a bunion? So a bunion looks something like this. And more specifically, it looks something like this. So generally speaking, the prominence on the inside part of the toe, around the big toe, around here where the circle is what we would call a bunion. And if you compare the 2 feet, you'll see that the left side is pretty straight and the right side is on a wonky angle. Looking into it a bit more detail, if we were to take an x-ray, this sort of schematic version of an x-ray, we'd see a normal looking foot on the left side as we look at it with fairly straight bones and the bunion on the right foot. So what are we really looking at? Well, we're looking at these bones here. So these are the metatarsals, they're the long bones in the foot. And as you can see with the blue lines on the left-hand foot there, they're broadly speaking parallel. On the right foot, we see that those are much more splayed out and there's an increased angle between them. And as that happens, the metatarsal on the big toe side drifts inwards. The big toe falls outwards and tends to expose the area around here, and that becomes what we call the bunion. If you like, the ice cream falls off the cone, whereas on our normal foot, we've got a lovely straight ice cream sitting on top of the cone. Are these the problem? These aren't my Jimmy Choo shoes. They could be, but they're not. But are they the cause? Everyone comes in and tells me about the high heels that they used to wear or do wear or are not wearing. And are they the cause? Well, the answer to that is maybe, but there are lots of other reasons why people get bunions, and these include the following. So there's a very strong familial link in some families. My usual first question after someone tells me they've got a bunion is, who can you blame? And the usual answer is my mum or my grandmother. In the male side, it's quite strongly linked on the male side as well. But there are other causes as well, such as flat feet. People with flat feet are very predisposed to having bunions, but they don't have to get them. But the mechanics of the foot mean that a bunion's more likely. People with hypermobility, and those are people who are very bendy and very flexible. And sometimes that's very good news if you're a contortionist or a gymnast, but often for your feet, that may not be quite so good. And sometimes that enables or facilitates bunion formation. And most of the time, however, we don't have a cause of why people get a bunion. Are bunions a problem? Well, they're not always a problem. but they are a problem if they're painful, if they start rubbing in your shoe wear, and that's commonly what I see. If they're rubbing on the adjacent toe, the second toe, you'll see here that the big toe is pushing on the second toe, and not always, but often that can be painful. They can cause a deformity of the other toes, with that toe pushing to the side, as we can see in that picture there, or pushing up in the air or even underneath, and that itself can be painful and problematic. And in some rare cases, the skin on the inside of the bunion can rub so much that it ulcerates, or occasionally the toes can be rubbed on by the big toe and cause ulceration. And all of those reasons would be a reason to consider intervening if you had a bunion. So what can we do? What do we recommend? Well, everyone should have what we would consider to be non-operative treatment first. And that includes a lot of simple things that are going to be relevant to many of the conditions we talk about this evening. So modifying people's activities. If you run marathons for a living, it might be sensible to run slightly less distance, and be careful what activities you want to take, because it might be that those activities are predisposing to your problems. You should consider shoe wear options. Skechers, I wish I had shares in Skechers. They're the shoes that people most commonly tell me are their most comfortable shoes. You don't have to get Skechers. You can get any pair of shoes that are comfortable, but you should certainly consider what shoes are comfortable. And in the world of bunions, you're looking for something that's wide fitting, often has a deep, what we call a deep toe box. That's plenty of room for the toes, can be a soft underfoot, and anything that's not going to squish your toes too tightly together. There's certainly a role for insoles and orthotics in some people for more comfort. And for pain, we'd consider the use of anti-inflammatories. This is Voltarol gel. There are plenty of others available. This is the gel, but there are tablets available, and painkillers can be useful for people who have pain. There's certainly a role for splints and spacers, and I'd suggest most people with a bunion should try something along these lines before they consider any other intervention. And there are many different options out there, and if you Google it, you'll find 100,000 different options, many of which are very simple, such as the first one on the left of the screen there, which offers a bit of padding. The one in the bottom of the middle of the screen there might separate your toes and prevent rubbing. And that one on the top right is super complicated, and I don't really see how that would be wearable with any kind of pair of shoes. So that's the sort of thing I don't recommend. So when I tell people to go and try different splints and spacers, it's the simple things that you might buy on Amazon for £5 or £10 that can often be the most effective. So once we've tried all of that, if people still have pain and want to consider doing something about it, we talk about surgery. So here's a regular looking bunion on the left side. You can see the splaying of the bones here between the first metatarsal and the second, and surgery can produce something that looks a little bit like this, with straightening out of the toe, and that procedure has a success rate of about 90 to 95%. It's an operation in the most commonly one in the UK, done in the UK is what I undertake, which is what most people do, which is called a scarf and Aiken osteotomies. In English, the scarf osteotomy and the Aiken osteotomy are just the techniques for cutting and reshaping the bones. Osteotomy meaning a breaking or resetting of a bone. And there are about 100 different descriptions of operations for bunions, all of which have, or almost all of which have a similar principle of breaking and resetting the bones in a straighter position. Like I said, this is a successful operation. There are risks with surgery, and we could talk about those if necessary, but by and large, most people with a regular bunion will have a good success rate following a simple operation like this. That's a day case operation, meaning you go home the same day. You can walk immediately afterwards, either flat-footed or on your heel. But most of the time we advise people to elevate the leg at rest and really keep weight bearing to an absolute minimum. And the recovery period does take quite a long time, which is sometimes what puts people off surgery. But as I've said, the success rate is really quite good. Not perfect, but pretty good. So here's another bunion. You might look at this bunion and think, well, that looks pretty similar to the other ones, and it does. But if we look a little bit more closely, we'll see that around this area here, the bones look a little bit less clear. The surfaces are a bit more roughened, and they certainly don't look as smooth as this one over the second or the third. And that's because this is arthritic. So this person's great toe has developed osteoarthritis, and as part of that, they may have then developed a bunion, or the other way around, in which case they may have had a bunion for many years that wasn't causing too much trouble, but became arthritic and became worn out and looked something like this. So this is first MTPJ, which stands for metatarsophalangeal joint, which is why we abbreviate it because it's such a mouthful, osteoarthritis, or wear and tear essentially. And we're looking at this joint just here. And I see this quite commonly as a problem relating to pain in the foot, and people come in and tell me they've got a bunion, and it's not quite as simple as a simple bunion that we might have just been looking at. So what can we do about first MTPJ osteoarthritis? Well, we can talk about all of the same things we've just discussed about non-operative management with activity and shoe modifications, insoles, splint spacers, anti-inflammatories and painkillers. And that again applies to everyone. And everyone should try these things and see if that's enough to be able to carry on leading the life they want to lead doing the activities they want to undertake. When we run out of those things, we sometimes consider the role for injections, something I frequently will arrange for to be undertaken through the Horder Centre, and we would most often do this under, now anyway, ultrasound guidance. So the ultrasound is usually managed and used by a radiologist, consultant radiologist, who specialises in this sort of thing, and that will enable them to guide a nice small needle into a quite small space, but accurately passing the needle, and that will give you the best chance of localizing the injection where it needs to get to with minimal discomfort. It's a procedure that people walk in and walk out from. They're a bit sore afterwards. They need to take it a bit easy for that day or the next day, but by and large carry on with normal life with not too much disruption. And that can be of some value in more mild cases of arthritis, or in people who would like to try other options that are not surgery before considering an operation. The time scale is quite variable, and most of the time if we do recommend an injection, we expect that it's going to improve matters for a period of time, and if it improves it for a significant amount of time, then it may be something that could be repeated, and sometimes more than just a few times, depending on the outcome that we see. Injections are not for everyone, and sometimes then we talk about surgery. So what are the surgical options in this situation for arthritis? Well, we can do what we would call a cleanup. So this in medical speak is called a cheilectomy. We like to give everything long, complicated names to make it sound exciting, but it's basically a cleanup. And when we look at an arthritic joint, we often find knobbly, bumpy bits of extra bone that have formed as part of the arthritis, and in themselves, these can be quite painful. So knocking off the knobbly bits and giving everything a good cleanup, which is a relatively straightforward, easy day case operation, can work quite effectively. It's not for everyone, and in more severe arthritis, it doesn't work. It is to be viewed as a sort of halfway house, if you like, to a more invasive procedure, and almost a delaying of the inevitable in some situations. So it has a role, but in more limited cases usually. Replacements, they do exist. You can have a big toe replacement. They, however, have a very high failure rate, and so are very rarely undertaken. I don't do any. I don't know anyone locally, as in the southeast, that does, and I would not recommend having a replacement first MTP joint, but there are people that have had them done years ago, some of which are still going and some of which failed very early on, but generally the perception is the replacements fail very early. The standard operation we would undertake is a fusion, and that involves locking the bones together. This is the gold standard operation. It works extremely well, and it has a highly predictable success rate. And a fusion might look something like this. And what we're talking about really is bolting the two bones together and getting them to knit together as if they were one broken bone. And if they were out of alignment to start with, we can straighten the alignment, as you can see with these cases. If the toe is already straight but worn out, then it doesn't need to be changed. The position doesn't need to be changed, but nevertheless, it would be fused in the position it's in. And we can use a combination of plates or screws, or just screws, and it doesn't really matter how the toe is fused. People use different techniques, but they're generally very successful, and it's a predictably good operation with about a 90, again possibly even 95% success rate in terms of making someone's toe pain-free, and generally that's what their problem is. So if you can improve someone's pain, they will walk normally. There's the odd professional sportsman playing sport with a fused big toe, so the stiffness itself is not really an issue. It's the pain under control that people like, and it generally works extremely well. We're going to move on a little bit to lesser toes now. And what I mean by lesser toes is any other toe other than your big toe. And here's a not so pretty picture of a foot. That was danger warning number 1. And we can see here that we have the big toe crossing under, or the second toe crossing over the big toe. So this is a crossover toe, and we have a variety of different funny names for different shaped toes, ranging from hammer toes that many people will have heard of to claw toes, curly toes and mallet toes, and it all describes the different types of shape we see of funny wonky shaped little toes, and they can be very problematic in some people. This is a hammer toe. The drawing on the left shows that the toe is flexed up effectively, and as you might imagine, looking at the picture on the right, that red raw area can rub in shoes and can be very painful. And as you might expect, sometimes simple measures aren't enough to look after that problem. You can see that on the right hand picture there that this is associated with a bunion, probably is the underlying cause of this hammer toe. So this is an X-ray of a hammer toe. I'm not sure if that's projecting well, but you will see that the big toe here is running in a straight line, whereas the second toe is sticking up here and pointing back down. And I like to tell people that it's in its own postcode sitting up there, and you can see that how that might be problematic. So an operation that we might do to improve that would be to straighten the toe out by putting the bones in a straight line. And usually we would do that by putting a wire down the toe. And I like to use the word kebabbing, although some people don't find that too appealing. Kebabbing the toe in a straight line to improve the situation. So this X-ray that you can see down here, this patient's had another small little procedure done at the same time. So this bit here is not particularly relevant to the straightening of the toe, but this wire here holds the toe nice and straight while the joint heals in a straight position. And at 6 weeks after surgery, the wire comes out and the toe remains straight. Moving on to other causes of pain in the forefoot. So pain on the sole of the foot is generally called metatarsalgia, meaning pain in the metatarsals, and people often experience it where that hot spot is on that diagram here, where the sort of sun ray is underneath the ball of the foot. And you might have a look at this image here and see that actually there's some calluses or some hard skin, callosity, under the metatarsal heads there, and sometimes people will describe that as being very uncomfortable. That can relate to lots of conditions, and people often describe a sensation or feeling as if they're walking on a stone or walking on a marble, or there's something in their shoe or their socks rucked up. It's a very common condition, and we see it frequently, often associated with bunions or arthritis in the big toe. Some of the causes of metatarsalgia may be this condition called a Morton's neuroma. In this diagram here, the yellow lines represent the nerves in the bottom of the foot. So those nerves pass in between the metatarsals, and at the level of the ball of the foot, they divide and half goes up each side of a toe, and the nerve can get very much pinched in that area and can become very painful and become problematic. We consider using all the same things we've talked about previously with insoles and sometimes injections. And occasionally we end up doing an operation that generally works very well, where we may make a little incision over the top of the foot rather than on the undersurface, although you can go from the bottom, but most people would make an incision on the top, take out that swollen nerve and sew it all up again. And that is about 80 to 90% successful for people who have a confirmed Morton's neuroma on imaging. It's a relatively straightforward operation with a relatively easy recovery period. Believe it or not, we have a bunion, so we can have a little bunion, and we're going to call that a bunionette. So that's a problem that affects the little toe side of the foot with a similar kind of situation to a bunion effectively. And as you might imagine, that sticking out bit can rub in shoes and be painful. And there's a little operation we can do to address a bunionette if conservative measures with shoe wear and all the usual things we talked about haven't succeeded. And that generally works quite well. And can sort people's trouble out if they're struggling to squeeze into shoes, particularly those people who had wide fitting or wide feet and were forever struggling at Clark's as a kid to get hold of shoes for school. So that's a brief whiz through of the forefoot. So we're going to just move on now to the midfoot and to some extent then the hindfoot. So the most common thing I see in the middle part of the foot would be arthritis, but we also see it in the hindfoot. So here are a few x-rays. This is of an ankle. And this is the same ankle from the side, and we'll see there that there is a loss of the space in the joints here between the tibia, which is the shin bone, and the ankle bone here, and that represents wear and tear in the ankle, which we would call osteoarthritis. But there are other types of arthritis that can also cause this kind of situation, like rheumatoid arthritis, for example. This is an MRI scan of a foot looking more at the middle part of the foot, and some radiologists here has very carefully highlighted with a lovely white arrow a bit of bone that looks whiter than the rest, and that's because there is osteoarthritis affecting that bone there, which is the bone called the navicular, which sits in more in the middle part of the foot there. And arthritis can affect any of the bones in the foot, whether it's in the front, the back, or the middle. There are more classical patterns. For midfoot osteoarthritis, in the same way as we might address the forefoot with a big toe talking about a fusion, we also consider undertaking fusions in the midfoot. And a fusion might look something like this, again with plates and screws. In this instance, it's the second and third, what we call a raise. So that's the second and third metatarsals, and where they join to the little bones in the middle part of the foot that became arthritic, which is a common pattern. And this person's had a midfoot fusion with plates and screws, and this generally works well. But again, we'd always suggest people go through non-operative measures first, and often do have some injections before we would consider having surgery. Surgery is a good option, but it does come with a long recovery period and shouldn't be undertaken lightly. Let's talk about the ankle. So ankle osteoarthritis, it's a common condition I see. And here are two x-rays, or an x-ray of someone standing up, and we can look at both the right and the left as if we're looking at the individual. So if we look on the left side of their patient's left, which is the right side of the screen, we see a relatively normal looking ankle with a sort of symmetrical appearance of the space between the bones. Whereas if we look on the right side, we will see loss of joint space, particularly on this slightly outside part of the ankle here, where we have what we would call, or many people would call, bone-on-bone arthritis. We consider all the usual treatment options, including injections. Surgery, in this instance, took the form of an ankle fusion, along the same lines as what we've previously discussed. And here we've used 3 screws. Looks like 2 on the left x-ray, but actually when you look at them in a bit more detail, there are 3 screws there to join those bones together. And an ankle fusion is a very successful operation. Joining the bones together. That operation can be done both keyhole and open. Open surgery, meaning a cut down the front of the ankle, to use this method on the screen here, which is some screws augmented with a plate on the front of the ankle, which is slightly more solid construct. Or arthroscopic, which is medical speak for keyhole surgery, which is what the previous x-ray showed. There is no really good evidence that one is better than the other. Under certain circumstances, one is technically easier than the other sometimes. And generally speaking, I would tend to offer people arthroscopic surgery, i.e. keyhole surgery, if possible, and if not, then a plate and screws. But I can't categorically tell anyone that one is better than the other, and they both have really very good outcomes. Is there such a thing as an ankle replacement? Another common question. Well, the answer is yes, there is such a thing as an ankle replacement, but it's nothing like as common or as well researched, if you like, as a hip or a knee replacement, of which the Horder Centre is, a national leading institution in terms of the number of joints being put in place and the success rate. So yes, there is something as such as an ankle replacement, and it will look something like this. So on the right screen is an ankle replacement, one of the most commonly used ones in the UK. It's the type that I might use. The components are made of metal with some plastic in between. So the plastic is the butter in your sandwich between the 2 metal bits, and the metal bits are basically implanted into the bone. That's the bottom of the shin bone and the top of the ankle bone, and move and glide smoothly in that situation. So what's the difference between ankle replacement and ankle fusion? And that's quite a complex question with quite a difficult answer. And at the moment, we're in the middle. This is the only bit of research I'm going to tell you about, because there's lots of research, but this is a good piece of research called the TAVR trial. So TAVR stands for total ankle replacement versus arthrodesis, which is the medical word for fusion. So it's a comparison of ankle replacements versus ankle fusions. Undertaken at multiple centres all around the UK. That's the website for it. If anyone's interested, it's quite easy to remember because it's anklearthritis.co.uk. And it basically has randomised about 400 or so patients to either having a fusion or a replacement, and then comparing the outcomes. And the results essentially both show that both can give excellent outcomes most of the time, meaning about 90% of the time an ankle replacement or an ankle fusion is a successful operation and goes very well. They both have some risks associated with them, a slightly different risk profile. And at the moment, the jury really is out. Those that support ankle replacement will definitely tell you it's better. Those that don't support ankle replacement will tell you there's no difference. And the technicality of doing an ankle replacement is certainly more difficult than doing a fusion. And therefore, those that don't support replacement would tend to offer everyone a fusion, which is absolute gold standard, good or excellent offering and outcome, and you cannot really tell them that that is anything other than the right thing to do. But there is a role for replacement, because in theory it will keep the ankle moving, whereas an ankle fusion will stiffen the ankle. And those that have ankle replacements that move generally will tell you that they like maintaining the movement, although all of the outcome data will tell you that pain is the key feature, and as long as you eliminate people's pain by whichever method, they will have an excellent outcome following surgery. Many people aren't suitable for an ankle replacement. Often patients are already very stiff with ankle arthritis when they come to see me. They've had it for some time. They've been trying to live their lives and get on with things, often very successfully, for many years. And by the time they get to me, often their ankle's already quite stiff as a result of the arthritis. And if that is the case, then actually an ankle replacement isn't going to get you any more movement than you've already got. So a stiff ankle with an ankle replacement put in is going to still be a stiff ankle. And in that instance, a patient is not suitable for a replacement, and they are better off having a fusion, which is an easier, simpler operation with a more predictable outcome. Those people with big deformity, that means they're wonky one side or the other, or people with significant loss of the bone from injuries, for example, again, they're not suitable for ankle replacements, and we know that those patients have a higher failure rate for ankle replacement, and again, they should all really be having a fusion operation. So the nuts and bolts of it is that the majority of people who come to me with ankle arthritis fulfill the criteria for a fusion more than they do a replacement, and therefore in my practice the majority of my ankle arthritis work represents ankle fusion. I do undertake some replacements as and when necessary, and generally speaking they do very well, but like I said, the majority of my practice involves ankle fusion. So whether you have a fusion or a replacement, the chances are you're going to do very well. I'm going to move on to sports injuries. Here we go. Here's a nice schematic of someone rolling their ankle. The key thing about sports injuries, or what we would call sports injuries, are they're not always sports. We've all walked down the pavement, been on a dodgy curb or a dodgy bit of patio and pavement or a pothole and sprained our ankle, and that was not a sporting injury, but it comes under the category in our world of sports injuries. The most common injury that falls in this group would be an ankle sprain. So an ankle sprain is a ligament injury, and ligaments connect bone to bone, so they are stabilizing in the part of the world, the ankle. We have ligaments everywhere, like our knee and our wrist, for example, and our elbow, and when you go over on the ankle you will injure those ligaments, and that is what an ankle sprain is. Ankle sprains can be mild, which is usually just a stretch of the ligaments, moderate, which is a partial tear maybe, or severe, which is a complete tear of the ligaments, and that's how we would grade them. Having said that, there is no predictability between whether you have mild, moderate or severe sprain on imaging and scans as to whether or not your ankle is going to get better. So an ankle sprain looks something like that. That's where you might injure your ligament, and most will get better. 95% of people who sprain their ankle, and I'm pretty sure that everyone listening to me drone on here has probably sprained their ankle at some point, and most people will have got better from that sprained ankle. Early on, the treatment that we'd recommend is all that first aid treatment we've always heard about: RICE, rest, ice, compression and elevation. The same thing you should do for any other injury. That should be what most people need to do early on. After that, time, physiotherapy with some rehabilitation often, and the vast majority of people will get better. However, there are a small number of people who will carry on with ongoing pain or a feeling of instability in the ankle. And like I said, that's probably less than 5% of all the people that sprain their ankle. So we would usually wait at least 6 weeks after that kind of injury to see how people are going to progress. And often at the 6-week stage, a few people come back saying that they're really struggling. If people are improved, although not perfectly better, I'll often tell them to just wait a little bit longer, give it more time, and most will still settle down. But if there is significant pain or a feeling of instability of the ankle, we would usually, in the first instance, undertake an MRI scan, because that will give us most of the information we need to know about exactly what the injury is, and it will exclude other injuries as the cause of the pain, such as a break that people didn't know about, or a tendon injury that may be accounting for the pain. One of the first line treatments we might consider with ongoing pain despite things like physiotherapy would be to consider an injection in the ankle, and that can often be helpful. For those people that really persist with pain and good evidence of ligament injury, we can consider different types of surgery. Sometimes we will consider a keyhole operation, which is an arthroscopy, to clear out the ankle, and that would look something like this. So we use a little telescope, which is the thing on the right hand side that you can see there, and that will look inside through a tiny little hole. So this telescope that we use is smaller than a biro, and that little hole that we make will have one stitch in it at the end, and then we'll make another little hole where we can pass an instrument in that can help us clean up and clear out and assess the ankle. And we might need to clean up some soft tissue, we might need to take away any ridges or spurs of bone, and again there will be one little stitch in that hole as well. So an arthroscopy, a keyhole cleanup of the ankle, which is sometimes needed, is a relatively straightforward operation with a relatively quick recovery period depending on what we need to do. With small incisions and undertaken as a day case operation under general anaesthetic. Sometimes we need to reconstruct the ligaments as well if patients have ongoing instability because the ligaments effectively haven't healed up properly. And a ligament reconstruction might look something like this on the inside. So this is a schematic diagram. You might see over here that this is where what we call the lateral ligament complex exists between the fibula, which is the little bone down the outside of the ankle, and the ankle bone here. And this sort of sheet of tissue, if you like, is a representation of part of the lateral ligament complex, which is the ATFL, or the one that's most commonly injured. Here, the ATFL, or the ligament, has been effectively stitched back onto the bone through little anchors here, and then an artificial ligament has been passed over the top here, which is something I now do routinely, that was developed more for the sports elite athletes sort of group of patients, to reinforce the repair as, if you like, an artificial extra ligament over the top, and that gives us a bit more confidence about getting people going a little bit quicker. Historically, we would have put people in plaster for 6 weeks after this kind of surgery, hopping around, taking it very easy. Now I tend to put people in plaster for 2 weeks, hopping, but hopefully doing nothing but sitting at home, maybe watching the whole of Netflix or doing a few crosswords. And after 2 weeks, going into an ankle, a walking boot, so one of those big black ski boots you might see people stomping around in, and letting people weight bear after week 2 until week 6. During that time, they really need to treat the boot like a plaster cast, insofar as not really taking it off or doing anything with the ankle, but nevertheless they are able to weight bear, which is certainly a bit of progress from where we used to be. And generally speaking, the success rate from these sorts of surgery is about 80%. Most people can return, if we're talking about sports, to their sporting activity at about 3 months and into their normal shoe wear by about 6 weeks, but certainly needing physiotherapy for onward rehabilitation. Other sports injuries. So it's not always just a sprain, and that's one of the reasons we do get MRI scans and x-rays after the 6-week stage, because things are often put down by the emergency department or A&E as it's a sprained ankle, you haven't broken anything, don't worry about it, it'll all get better. When it doesn't get better, it isn't always just a sprain. Here we go. This is our national newspaper telling us all about David Beckham's foot. Beck us pray, he broke his metatarsal, and everyone was hoping that he might get better for his for the Euros, I think it was, and this made it to the front of the paper. So people can break bones and that not always be visualized on x-ray. Sometimes MRI will highlight, or CT scan will highlight broken bones that haven't otherwise been seen. Sometimes people can rupture their Achilles tendon. That's a bad injury, it takes a long time to recover. There are other ligaments around the foot and ankle that can also be injured on the inside part of the ankle and also a little bit higher up, and these come with slightly differing treatment protocols. And sometimes people can experience nerve pain after a simple rolled ankle or other kind of sports injury, and that can cause some ongoing discomfort. So a sprain is not always just a sprain, and there is often usually a cause, but sometimes it needs a bit of extra investigation. The good news for most of these is that they get better without the need to intervene, but sometimes things like Achilles tendon ruptures or other ligament injuries do need or do warrant consideration of surgery. We'll move on a bit further back in the foot now to the heel. Plantar fasciitis. The plantar fasciitis is the bane of all of our foot and ankle surgical lives. It is very painful. Just there, just where that person is pushing on their heel. It used to be called policeman's heel, for some people who may have heard of that from all the police bobbies stomping around on their beat. There's some great news. It almost always gets better. There is some bad news. It can take a very long time, and it's very, very frustrating. The treatment is simple. It's stretch, stretch, and more stretch. And the stretching that we recommend is stretching people's calf muscles. They're often extremely tight, and almost everyone with plantar fasciitis has very tight calf complexes, and the plantar fascia itself needs stretching. And usually, therefore, we would recommend referral to physiotherapists for those stretching exercises, and that will get the majority of people better. I'd recommend some jelly kind of heel insoles that are very easily and cheaply available. cost a few pounds to cushion under the heel. And the mainstay of management should be physiotherapy and insoles. And sometimes for people who haven't got better, we consider the use of shockwave treatment, which is high energy ultrasound. And that will get a small number of people who haven't already got better to get better. So most of the people that get to me have tried some of these things already, but if they haven't, they absolutely must. And the vast majority will get better with this selection of interventions. So when people come to see me in clinic, I will usually arrange for them to have a scan of some description to confirm the diagnosis, and then recommend this kind of management, because the other options I really would not advocate. So injections are historic. They were always done for plantar fasciitis. They are extremely painful, and if I did know better, I would tell you that they are more painful than childbirth. I can't quite vouch for that, but it's what everyone tells me. There is a risk of damaging the plantar fascia with the injection and of causing a rupture of it, and that is the reason that I and many of my colleagues no longer undertake injections around the plantar fascia. There are some other products out there, and some things called PRP, for example, which is platelet-rich plasma, that really have very limited evidence, but people are undertaking it. It's not something I would routinely recommend or do. There is a very limited role in a very select number of people for surgery. I do undertake it as necessary. It usually involves a calf muscle operation to try and stretch out the calf muscle surgically, rather than doing the physiotherapy or having failed the physiotherapy. But generally speaking, most patients do not need an operation, and I would not advocate one. Moving on to the Achilles tendon, it's really what we now call Achilles tendinopathy, is sort of a new name, which is based on microscopy and clever science for what we used to call Achilles tendonitis. And it's very commonly related to tight calf muscles that are a similar finding, if you like, to plantar fasciitis. The mainstay of treatment, once again, is stretch, and more stretch with physiotherapy. And again, also a role in many cases for shockwave treatment if that doesn't improve matters. Injections around the Achilles tendon are an extremely bad idea. I don't recommend them, and I wouldn't suggest anyone lets anyone else near their Achilles tendon with an injection because of the risk of rupture. It is a bad idea, and you should certainly think twice about doing that. Sometimes people do need surgery. It's a big undertaking. It can work very well if it's needed. So here's an operation that involved having to take the Achilles tendon off the bone and effectively cleaning it up, clearing it out, removing some of the bony prominence associated with it. It's called a speed bridge procedure, and it can work very well if needed. And I do undertake a reasonable number of these, but it's not for everyone, and they certainly should have exhausted all the other non-operative treatments first. Flat foot, fallen arch. Here's some schematic of that. So a nice healthy looking arch on the left, and we see a flat foot on the right. It doesn't have to be painful. Usain Bolt has the flattest feet in the world, and it doesn't stop him from running extremely fast. But when you take this plantar plate print, if you like, of the foot of someone standing up in the sand or on one of those sort of clever mechanical pads, you'll see the imprint made by the foot, and it definitely changes the mechanics of how the foot is put onto the ground, and it can be very painful. Someone with flat feet, this is an extreme example, might look like that, and you might imagine that is quite uncomfortable. It generally relates, in the majority of people, to a problem with this tendon, which is called the tibialis posterior tendon. And it's the main tendon running down the inside of the ankle, and it joins onto that navicular bone, which is on the inside part of the foot, which we can see sort of over here, and that holds your arch up. So when that tendon stops working, the arch will stop being held up and eventually may collapse. And when it does collapse, it can be very painful, and in some situations can then lead on to development of further trouble, such as arthritis, because of the position of the bones being out of alignment. In the mainstay, the initial treatment should be insoles, and as you can see here, this is an insole with a nice arch support on it. And as you might imagine, that will support the arch and do some of the work of the tendon that's not working properly and holding the arch up. Sometimes we have a little lift on the heel that can just tip the foot into the right position and stop it from falling out of position. You should consider the role for ankle supports, different types of shoes, some physiotherapy to strengthen the ankle, sometimes a role for injection, and then surgery is a big undertaking. Again, we do it as necessary for people who don't succeed with this sort of treatment, and it can work very well in certain instances, but it is a long recovery period. other conditions that we haven't talked about and I'm not going to talk about, but I see frequently. So here's a broken ankle that's been fixed relatively well with no concerning features here. This is called a bimalleolar ankle fracture because it involves both sides, both malleoli, and it's been fixed with plates and screws. And most people after surgery will make a good recovery, but it can take a long time. And some people run into trouble and come to see me about that. I see lots of lumps and bumps around the ankle, like ganglions, for example. I see some neurological problems. So in the hand, a common condition we see is carpal tunnel. Believe it or not, there is a tarsal tunnel syndrome. And there are lots of other nerve compression syndromes that can exist around the foot, causing ongoing symptoms. I haven't, you'll be glad to know, put some pictures of some manky toenails up, but there's no doubt I see them. I see plenty of them. And there are lots of treatment options available if a podiatrist or a chiropodist can't resolve the toenail problem. And I see lots of deformities of people's feet that might look something like this. This isn't a real deformity, I would say. This is a crazy operation called a rotationplasty, which is undertaken for very unfortunate people who have tumours in their legs that need them excising, and the foot being put on backwards like a knee, believe it or not. Never seen one. It's only ever very rarely described, but it makes for a very interesting photo at the end of our presentation. Thank you for coming. I hope I haven't spoken too quickly. It's a huge topic to whiz through. There are tomes and tomes of textbooks to discuss and lots of different conditions, and I could bore you all for hours with these sorts of things, but you've probably got better things to do. I'm happy to take any questions, and thank you very much for coming.
Okay. Right. Thank you, Ms. Rose, for those really valuable insights and walking us through the different treatment options, and also for making it quite funny too when talking about feet. I have noticed, by the way, we've had quite a few people have actually signed in during the presentation, so I just want to reassure you all that you will be receiving a copy of this webinar tomorrow by email, so you can catch up on that. In the meantime, thanks for everyone for posting your questions. If you haven't posted one already, then please do so now, and don't forget, if you want to stay anonymous, then you just tick the little tick box at the top. So I will start and reading out the questions. I do need to sometimes refresh this just to pull them through, but anyway, over to the first one. Which is how to deal with thinning of sole skin, probably caused by previous excessive running plus old age, now causing painful walking and swelling, also combating very dry skin on feet.
That is actually quite a tricky problem, and it sort of depends about which part of the foot you're talking about. Some people come in with a condition around the bottom of their heel where they feel like they've lost some of the padding under their heel, and that was called heel fat pad atrophy. That's a very difficult condition to treat, and the mainstay of treatment for that would be some insoles to pad underneath the heel. As far as the front of the foot, which is probably what you're referring to, people can experience thinning of the skin and effectively exposing of the undersurface of the bones, and it'd be very painful. That comes under really the remit of metatarsalgia, one of those conditions I mentioned earlier. It depends if there's any mechanical problem that causes that in the first place, and we'd obviously have to assess that with imaging as to whether there's a reason why those specific areas at the front of the foot might be taking too much pressure and therefore causing a thinning of the skin. There isn't an easy way to sort of bulk out the skin, if you like. There's no implants or injections or fillers that are of any value that I'm aware of, and I'd certainly be very wary of anyone sort of cosmetically trying to consider treatment for that. The absolute mainstay of treatment for that usually would be insoles with padding under the front of the foot, but in some people who have things like quite a stiff ankle, which means that you're effectively putting more pressure on the front of the foot because you just can't get the foot up too high, there can sometimes be a role for releasing structures in the calf to give you a bit more movement and take the pressure off the front of the foot. And we do quite commonly undertake a calf release operation for forefoot trouble that, believe it or not, is quite an easy, quick recovery period. It feels a little bit like a pulled muscle, and you can walk straight away after it. It's not for everyone. It's very select cases. There are essentially, really, though, the mainstay treatment is non-operative management with good insoles. And I would usually recommend in that instance some custom-made insoles from a biomechanical podiatrist.
Okay, thank you. On to the next one. And how long is the recovery period for ankle fusion?
Okay, so that does vary around the country in terms of what people do. In my world, and I can tell you what I do, which is essentially probably the current standard for most, but not all, it would be overnight in hospital for most people, assuming that they can hop successfully the next day. Very occasionally people go home the same day if we manage to get the operation done first and they can successfully, safely get up on some crutches with the physiotherapist. But for most people, overnight in hospital, hopping around in a plaster cast for 2 weeks, non-weight bearing, strictly non-weight bearing, sitting at home with your foot on the sofa, getting up for life's necessities, but otherwise doing nothing for 2 weeks, followed by a follow-up appointment in clinic where I would see people, and usually, if all is well and there were no other undue circumstances, put people into a walking boot at that time, one of the big black ski boots, get walking slowly but surely with some crutches at that point, and just begin to take weight as people feel comfortable. Some people carry on hopping because it's a bit sore still. Some people are ready to walk straight away, and people would be in a boot until the absolute earliest to come out of the boot would be week 6, and many are in a boot until week 12. Historically would have been 6 weeks in plaster followed by 6 weeks in a boot. So we've moved things on a little bit now and trying to get people going quicker, trusting patients will know best around their symptoms and how their body is doing. So after 2 weeks walking, up to 3 months in a boot, depending on progress, but maybe less, to get over the whole thing and forget you've had an operation. 6 to 12 months, which is quite a long haul, but you're certainly obviously walking in the earlier stages.
Okay, thank you. I've got one here from David, but I can't see the one attached to it. He says, sorry, I meant barefoot trainers for ankle issues. Are they any use?
I don't like barefoot trainers. I have an excellent friend from school who's an osteopath who runs Ironman and all that sort of stuff, and he swears by them. I don't like them because I think they offer minimal support, and I think they would put more pressure on the front of the foot. If they're comfortable, then they're fine. I'm very unprescriptive, if that's a word, about shoe wear. People often ask me what to wear. They should wear whatever's comfortable, because we're all different, and we all experience pain somewhat differently, and our feet are all shaped slightly differently. So people should wear the shoes that are most comfortable, even if people tell them that they shouldn't be wearing those shoes. Whatever you find comfortable is the right shoe for you.
Okay, thank you. Is there any help with psoriasis arthritis on foot?
Yes, so psoriasis arthritis, what we call psoriatic arthritis. Yes, it comes in the same category, if you like, as rheumatoid arthritis, insofar as there's a condition where your body causes some of the destruction to your own joints. The end result of that is often that people get wear and tear, and they effectively develop what I've shown you here with osteoarthritis as a result of their condition, but the mechanism of getting there has been different. Osteoarthritis is effectively a wear and tear condition, sometimes relating to an original injury. Psoriatic or psoriasis related arthritis, or rheumatoid arthritis, or any of these other arthritis or arthropathies that are rare but described, cause all of the same sort of things I've already discussed, and most of the treatments I've discussed tonight are relevant for psoriatic arthropathy, is what we call it, psoriasis related arthritis, whether most of the time that would be fusions, but before that the same sort of things around injections and all the non-operative management.
Okay, thank you. Could I ask what injections consist of, and also what side effects are there?
Yep, so really the only injections that I undertake and that essentially are licensed in the foot and ankle are what people would call cortisone injections. In just breaking that down a bit, it's a steroid injection. So we use a combination of steroid and which is what cortisone is a type of, as well as local anesthetics. The same sort of stuff that you'd have if you had stitches in A&E, for example, would go in with the steroid to numb the area, and a bit of longer acting local anesthetic, the same as if you had a let's say a dental injection that kept your mouth numb for the next day. That combination of local anesthetic in with some steroid into the joint, directly injected into the relevant joint. There are some other injections out there, like I've said, PRP, which is platelet-rich plasma. That is your own blood taken, spun down in a centrifuge to get different sections of the blood, depending on which bits are in it, and a specific piece of that taken out called the platelet-rich plasma, and that stuff then re-injected in the available or the relevant area. The evidence for that is very sketchy. It's a procedure that I have only done a couple of times because I'm waiting for anyone to tell me there's actually any evidence it works, and I would be dubious about its use, so it's not something I would routinely recommend. It's not dangerous, it's your own blood, but the evidence it works is very sketchy. There's a few other injections out there that have got very little evidence, and I put in the category voodoo.
Okay, thank you.
One more thing, sorry, just to go back to that. Recently in the knee and in the hip, there's a recent injection come online that's being used at the Horder Centre called arthrosomid, and that is not licensed for the foot and ankle, so we cannot use it. Equally, historically, people used Ostenil or other high hyaluronic acid injections, which are artificial joint fluids. Again, they're not really well utilized in the foot and ankle, and they're not specifically licensed for that. It's off-label if you use them, and there's no really good evidence they work.
Okay, that's really helpful. Okay, I have debilitating soft tissue pain in my ankle. I broke it 5 years ago and it has metalwork. X-rays confirm the break mended well and there is no arthritis. Exercises from a physiotherapist have not helped. Can Mr. Rose suggest anything to help soft tissue pain?
Well, the first thing to say is that the X-ray may well have confirmed that everything's healed, and it probably has after a broken ankle. And it may suggest there's no arthritis, but that isn't always completely clear. There are a significant number of people that experience degeneration in their ankle after breaking it, and not everyone makes a full recovery. So whilst there may be some pain from soft tissue, it may not be quite as straightforward as that. And if you haven't already had further investigation, then you probably should. If there's metalwork still in there, then an MRI is also valuable, because the metalwork sort of shoots shards of white all over the pictures and you just don't get a good image. The CT scan is usually the first port of call to look at the state of the joints. However, there are lots of other things that can cause pain relating to ankle fractures. Sometimes the tendons around there can get all stuck down in the healing material around the broken bones. Sometimes the ligaments have been injured. So it's not quite as straightforward as to say the broken bone has healed and therefore there is no other ongoing problem. The end. There are potential other causes that can be addressed, and most of the time, if people have pain after a broken ankle, we can identify a reason for it. It depends what that reason is as to whether there's an easy solution. Sometimes a bit of nerve pain, but if there is some arthritis, even if it doesn't look like that on an X-ray, then there are many treatment options, but it would need investigating in a bit more detail. So I don't think just being labelled soft tissue pain 5 years down the line from a broken ankle is necessarily the end of the story. And I would have thought that more investigation would be warranted.
Okay, thank you. My feet are getting very hot and feel prickly on the base of the soles at night. Also, when I've been on my legs walking at work, etc. Not sure what to do to stop this feeling. Also, the area at the bottom of my toe joints on the top of my feet hurt to wriggle my toes.
So the hurt when wriggling toes, I mean, I don't know who you are, how old you are, and what you do with your life and what you've done with your feet. However, the wriggling of the toe may well be a bit of wear and tear. In the big toe specifically, that's a very common thing. Feeling of prickling and heat, that kind of description often falls under a sort of neurological or nerve-related discomfort. And we do, there are a well-described condition called peripheral neuropathy, or nerve pain, essentially relating to damage to some of the nerves. That's common in diabetes, but you don't have to have diabetes to have nerve pain. But equally, other causes of nerve pain can actually relate to people's backs, where they can have a sort of form of, sciatica or a version of that can actually cause nerve-type symptoms into the feet. So there are lots of different causes that may not be structural as such in terms of damage or malalignment or problem with the bones or the architecture of the foot, but nevertheless can cause trouble, and that would need to be investigated, possibly seeing a neurologist or having investigations around the nerves in the first instance.
Okay, next one. I've got a few questions here, actually. Hang on. It is, how common are problems? You have. How common are problems post-surgery from Morton's neuroma, numbness and instability of the foot?
So I'd say neuroma surgery, I almost always will arrange for people to have an ultrasound guided injection initially before they have an operation, to prove, if you like, that the neuroma is the thing causing the pain. Most people then who have an operation have got a reasonably clear identification, therefore, that the neuroma is the thing causing the pain. And I'd say the success rate is about 90%, which means there's a 10% risk of a problem. And of those 10%, the chance, I'd say the majority, which is a small number anyway, are people that still have some ongoing discomfort rather than a complication as such. But of course, like any operation, there are all the usual risks of surgery around things like wound healing problems, infection, even things like blood clots in the leg, which I've never seen after that kind of operation, a bit of stiffness or sensitivity sometimes of the scar. So all of these things really would account for every operation. Even in the best operation that is offered in the whole of medicine, which is a hip replacement, has a small complication risk associated with it, and the feet are no different. And in fact, every operation on the foot is slightly more risky than many other bits of the body, but I'd say the risk is low. And neuroma surgery, I've said 90%. I'd say, if I were being a slightly ambitious person, it may be even 95% successful if you choose the right people to have surgery.
Okay, do you know, this
was
was
the question about instability. If it's,
Oh,
I don't know if that question was also about ankle instability separately, but the success rate from ankle instability surgery is about 80 to 90%, with, again, ongoing pain or an ongoing feeling of instability being part of that sort of risk profile. But generally speaking, it's a very successful operation.
Okay, thank you. We've got 2 more questions for you, so the timing's been absolutely perfect. I have pain under my foot and swollen instep. What could this be and how to treat it? How do we treat it?
So the most common cause of pain on the bottom of the foot would be plantar fasciitis. That is the most common cause of pain in the sole. If it's more around the inside and actually within the arch rather than the bottom of the foot, then the options really are what we've talked about with regard to flat feet. So what I didn't tell you about was the problem with the tendon that we discussed. The precursor to the foot actually getting flat or becoming flat is a problem relating to the tendon, where the tendon has tendinitis or inflammation of that tendon before it gives up the ghost and stops working. And the early stages will cause pain around the instep of the foot and the arch and the inside of the ankle before people develop a flat foot. So early stages, if you like, flat foot development, may be caused by a problem relating to the tibialis posterior tendon. If that's the case, then I'd recommend you start with some insoles with a nice arch support and possibly some physiotherapy. If it's more on the sole of the foot, it's more likely to be plantar fasciitis. But, you know, as everyone else would say, there are other options available, other conditions available.
Okay, right, I can see we're actually running out of time, and the question actually that I'm left with that was within the presentation. Can I just say to everyone, thanks all for coming today, and thank you, Mr. Rose, for sharing your expertise, and everyone for joining us this evening. If you do have any further questions or you'd like to book a consultation with Mr. Rose, please don't hesitate to contact us via the details on screen now. That you've got the telephone number there, or you can contact us via email pp@horder.co.uk. When you receive the recording of tonight's webinar, which will be tomorrow, you'll also receive a survey link with a couple of questions for feedback, and we'd be enormously grateful if you would complete this. It only takes a couple of minutes, but it does help us to know what's working for you and whether there is any other areas that we can improve. But other than that, I think it just leaves us both to say thank you very much for joining us this evening, and enjoy the rest of it.